Welcome to Advanced Pharmacology. Today we'll be talking about Chapter 6, Adrenergic Bronchodilators. Adrenergic bronchodilators are also called sympathomimetic bronchodilators. This is from Rao's Respiratory Care Pharmacology, Chapter 6. Clinical indications for adrenergic bronchodilators. The general indication for use of an adrenergic bronchodilator is relaxation of the airway smooth muscle, especially in the presence of reversible airflow obstruction. This can be associated with acute or chronic asthma, including exercise-induced asthma, bronchitis, emphysema, bronchiectasis, and other obstructive airway diseases. The adrenergic bronchodilator group is used for the treatment of reversible airway obstruction in diseases like asthma and chronic obstructive pulmonary disease. These agents produce bronchodilation by stimulation of the beta-2 receptors on smooth airway muscle. Indications for short-acting agents, like albuterol, are reversible airflow obstruction in these diseases. Short-acting agents include albuterol, levobuterol, and metoprolol, though metoprolol or Alupent has been retired. In the United States, you will find albuterol and levobuterol most frequently. Short-acting agents are also called rescue drugs or bronchospasm relievers. These are indicated for the relief of acute reversible airflow obstruction. Short-acting bronchodilators are part of the National Asthma Education and Prevention Program Expert Panel Report, or the NAEPP Expert Panel Report Guidelines. Short-acting bronchodilators, also termed relievers, are discussed also in the Global Initiative for Asthma, or GINA guidelines. Indication for long-acting agents or long-acting bronchodilators, or LABAs. Long-acting agents such as salmeterol, formoterol, arformoterol, indicaterol, olaudaterol, and vilanterol are indicated for maintenance of bronchodilation and control of bronchospasm and nocturnal symptoms in asthma and other obstructive diseases like COPD. LABAs, or controllers, have a slow time to peak effect, and it makes long-acting agents a poor rescue drug. Ceravent shouldn't be taken when you need a symptom relief right now. They should only be taken as a maintenance medication. In asthma, long-acting bronchodilators are usually combined with anti-inflammatory medication for control of airway inflammation and bronchospasm. Many drugs, salmeterol, formoterol, are all may be combined with these inhaled corticosteroids. Although formoterol, indicaterol, and vilanterol have a rapid onset of action, similar to or better than that of albuterol, they are slower to peak in their effectiveness, and they have a prolonged activity that make them better maintenance drug or than acute relievers or rescue agents. Racemic epi should be used for its vasoconstricting effect to reduce upper airway swelling or to control bleeding in the airway. This agent should not be used to treat bronchoconstriction. Racemic epinephrine is often used either as an inhaled aerosol or via direct lung instillation, like during bronchoscopy. It's known for its strong alpha-adrenergic vasoconstricting effect to reduce upper airway swelling after extubation, during epiglottitis and croup, or to control bleeding in the airway during a bronchoscopy. Practitioners are urged to read package inserts on drugs before administration. These inserts give details of dosage strengths and frequencies, adverse effects, shelf life, and storage requirements, all of which are needed for safe application of the drug. Ultra-short-acting beta agonists. Ultra-short-acting means that their duration is less than 3 hours, include racemic epinephrine. Short-acting, or a duration of 4 to 6 hours, include albuterol and levobuterol. Long-acting, or a duration of 12 to 24 hours, include salmeterol, formoterol, arformoterol, indacterol, olaudaterol, and vilanterol. Let's talk about catecholamines. A catecholamine is a chemical structure consisting of an aromatic catechol nucleus and a dilymphatic amine side chain. Catecholamines, or sympathomimetic amines, mimic the actions of epinephrine more or less precisely. They can cause tachycardia, elevated blood pressure, smooth muscle relaxation, especially in the bronchioles and skeletal muscle blood vessels, glycogenolysis, skeletal muscle tremor, and central nervous system stimulation. Here is a catecholamine structure. Catecholamines consist of a benzene ring, 2 hydroxyl groups, and an amine side chain. The amine side chain is pictured here off the first carbon position. The catechol nucleus is this benzene ring. Adrenergic bronchodilators as stereoisomers. And what we're talking about is a R isomer or a right isomer, or an S isomer, a left isomer. They're like mirror images of each other chemically. Adrenergic bronchodilators can exist in 2 different spatial arrangements, which produce isomers. Rotation around the B carbon on the ethylamine side chain of the basic molecular structure, as seen in your book in Figure 6.1 on page 93, and we'll take a look at it next, produces 2 non-superimposable mirror images termed isomers. Figure 6.2, Figure 6.1 shows the S epinephrine isomer, and Figure 6.2 shows the right epinephrine isomer. The R-isomer or levoisomer is active on airway beta receptors producing bronchodilation and on extrapulmonary adrenergic receptors. The S-isomer or dextroisomer is not active on the adrenergic receptor sites, such as the B receptors. And until more recently, the S-isomer was considered physiologically inert. The two mirror images of the isomers rotate light in opposite directions, providing the two isomers, and this is the basis for designating them as either dextrorotary or levorotary, D plus or L minus, using their actual spatial configurations. The levoisomer and dextroisomer are referred to simply as the R isomer and the S isomer. Adrenergic bronchodilators such as epinephrine, albuterol, and salmeterol all have been produced synthetically as racemic mixtures, or a 50-50 mix of the R isomer and the S isomer. Natural epinephrine found in the adrenal gland occurs as the R isomer or the levoisomer. Levobuterol, released in 1999, represents the first synthetic inhaled solution available as the single R isomer of racemic albuterol. Other atoms on each side, it means that it's got a longer side chain too. Structures that are currently available as inhaled beta agonists will be discussed later. Here you can see the S-epinephrine and the R-epinephrine. Epinephrine is a potent catecholamine bronchodilator that stimulates both alpha and beta receptors. Because epinephrine lacks a beta-2 receptor specificity, there is a high prevalence of side effects, such as tachycardia, blood pressure increase, tremor, headache, and insomnia. Epinephrine does occur naturally in the adrenal medulla and has a very rapid onset, but a very short duration because of metabolism by catecholomethyltransferase, or COMT, C-O-M-T. It has been administered with asthma exacerbation. It is also used as a cardiac stimulant on the basis of its strong beta-1 effects. Self-administered intramuscular injectable doses of 0.3 milligrams and 0.15 milligrams are marketed to control systemic hypersensitivity reactions or anaphylactic reactions. I carry an EpiPen so that if I get stung by a bee. This drug is more useful for the management of acute asthma rather than for daily maintenance because of its side effects and short duration. I mentioned side chains. Let's talk a little bit about that. This is called the keyhole theory of beta-2 specificity. The theory explains the shift from alpha activity to beta-2 specificity has been termed the keyhole theory of beta sympathomimetic receptors. In other words, the larger the side chain attachment to a catechol base, the greater the beta-2 specificity. If the catecholamine structure pattern is understood as a key-like shape, then the larger the key or side chain, the more lung or beta-2 specific the drug is. The increase in side chain substitutions can be seen in drug structures present in the book. This can be found on page 94. I've mentioned the metabolism of catecholamines, so let's talk a minute about that. Catecholamines may be rapidly inactivated by COMT, cytoplasmic enzyme. This enzyme is found in the liver and kidneys and throughout the rest of the body. The action of COMT as it transfers a methyl group to the carbon-3 position on the catechol nucleus. The result is that it inactivates the adrenergic receptors. Because of the action of COMT or CMT on circulating catecholamines is very efficient, the duration of action of these drugs can be severely limited, with a range of only 1.5 to at most 3 hours. Catecholamines are also unsuitable for oral administration because they are inactivated in the gut and liver as well. They can also be inactivated by heat, light, and air. For this reason, racemic epinephrine is stored in an amber-colored bottle or a foil-protected wrapper. Nebulizer rainout, those particles that condense and fall under the influence of gravity in the tubing, may appear pinkish after treatment, and a patient's sputum may even appear pink-tinged after using aerosols of catecholamines. This is the mean percentage change in FEV1 from baseline to the end of treatment, week 4, with various doses of albuterol, racemic albuterol, and placebo. Placebo is pictured here in teal. Albuterol 1.25 is here in dark blue. We're going to talk for a moment about resorcinol agents. These are better for maintenance therapy in COPD and asthma. They have a significantly longer duration of action, 4 to 6 hours, and a slower peak effect, 30 to 60 minutes. A few examples of resorcinols are terbutaline and metaproterenol. And if you've never heard of these drugs, there's a reason. Alupent was taken off the market in 2010. And terbutaline is used mainly to prevent premature contractions. As an inhaled nebulizer, it's only used when a patient is allergic to other sympathomimetic bronchodilators. Let's talk about the salinogen agents. You are much more likely to see these as a rescue source for bronchodilation. Examples of salinogen bronchodilators are albuterol, also called Proventil, Ventolin, ProAir, and AccuNeb. These are available in a multitude of different styles: metered dose inhaler, solution for nebulizer, unit dose for nebulizer, syrup for children, sprinkles, and extended release tabs. Similar to the resorcinol bronchodilators, this drug has a beta-2 preferential effect. It also is effective with oral administration. However, you're much more likely as an RT to see inhaled albuterol. That has a duration of action of 4 to 6 hours with a peak effect in 30 to 60 minutes. Duration of action, though, can be achieved with oral administration of up to 12 hours with extended release tabs. But oral use may lead to a greater systemic side effects than the inhaled counterpart. Some of the benefits of salinogen agents include beta-2 preference. They're effective when taken by mouth. Their peak effect is in 30 to 60 minutes, and they last for 4 to 6 hours. Another thing you'll commonly see in your clinical sites is the pure R isomer of racemic albuterol, also called Xopenex or LAButerol, pictured here. It is available as a meter dose inhaler or a nebulized solution, both in bottles and unit dose. There are 4 nebulized doses that are common: 0.31 milligrams in 3 cc's of normal saline, a half dose, 0.63 milligrams in 3 cc's, also a unit dose, or more commonly 1.25 milligrams in 3 milliliters, and as a concentrate, a unit of use, in case you have to give a double dose for a treatment, a 1.25 milligram in a 0.5 ml of concentrate. Here's what those look like. The R isomer and the S isomer of racemic albuterol. LAButerol is the single R isomer form of the racemic albuterol and contains no S isomer. Effects and characteristics of the S isomer of albuterol. It increases intracellular calcium concentration in the body. Activity is blocked by anticholinergic agent atropine. It does not produce pulmonary or extrapulmonary beta-2 mediated effects. It enhances experimental airway responsiveness in live tissue. It increases contractile response of bronchial tissue to histamine or leukotriene in the body. It enhances eosinophil superoxide production. It is metabolized slower than the R-albuterol in the body, and it preferentially is retained in the lung when inhaled as a meter dose inhaler. Single R isomer formulation of albuterol or LAButerol. Side effects include tremor and heart rate changes that were less than albuterol. It comes in a 1.25 milligram LAButerol dose, which showed a higher peak effect on FEV1 than racemic albuterol. Side effects were similar, with similar dosing to racemic albuterol. Long-acting beta-adrenergic agents. There's a trend in adrenergic bronchodilators, and it's been towards development from non-specific short-acting agents such as epinephrine to beta-2 specific agents with a long duration of action. Longer-acting agents offer the advantages of less frequent dosing and protection all the way through the night for patients with asthma. These drugs include extended-release albuterol and newer drugs such as salmeterol or Ceravent, Perforomist or formoterol, Brovana, Formoterol, and Arcapta-neohaler, as well as Straverti Respimat. The long-acting bronchodilators are contrasted with short-acting agents. Short-acting agents include albuterol and levobuterol, and although these agents at one time were considered longer-acting as compared to ultra-short-acting catecholamines like racemic epi, they do not last 12 hours. So in other words, ultra-short-acting, less than 3 hours. Short-acting, 4 to 6 hours. 12 hours or more are considered a LABA, or a long-acting beta-adrenergic bronchodilator. Extended release albuterol is available as Vospire ER, pictured here. It comes in a 4 milligram or 8 milligram oral tablet. The 4 milligrams are green, the 8 milligram are tan, and it lasts 8 to 12 hours. Ceravent, or salmeterol, is available as a dry powder inhaler, or a discus, pictured here. Bronchodilator, it has a bronchodilator effect with a slower onset than albuterol, about 20 minutes, and its peak effect is actually in 3 to 5 hours. The duration of action is 12 hours. This is one of the most common LABAs that you'll see, and often combined with a corticosteroid. Formoterol is common in Europe and gaining preference here. It's beta-2 selective. It comes on pretty quick, about 3 minutes, but lasts up to 12 hours. It's available as a small volume nebulizer and as a dry powder inhaler. The dry powder inhaler is pictured here. It's used for asthma. It's also used for exercise-induced bronchospasm for 5 years old and older, and used in COPD. Salmeterol and formoterol inhibit mast cell activation, so they have some anti-inflammatory effects. However, this is still under investigation and has not yet been clinically proven. Let's talk for a minute about Brovana. It's a beta-2 selective agonist with a long-acting bronchodilator effect of up to 12 hours. It's available as a nebulizer solution and works well for maintenance of COPD. Maintenance therapy for asthma not controlled by inhaled corticosteroids may also be used for, but more commonly in COPD. Arcapta-neohaler. Arcapta-neohaler is a beta-2 selective agonist. It's available as a dry powder inhaler. It is ultra long lasting. In fact, the duration of action is up to 24 hours, and it's approved for the maintenance treatment of COPD. It has a very quick onset of action, about 5 minutes. So it's a first-line treatment for COPD. Here's what it looks like. Striverdi-Respimat. Striverdi-Respimat is also an ultra-long-acting beta agonist that was approved by the FDA in 2014. The dose is 5 micrograms once daily via the Respimat pictured here for treatment of COPD. It has a quick onset similar to formoterol, and the change in FEV1 is seen in approximately 5 minutes. It's been observed to have a 24-hour duration of effect in patients with COPD. Currently, it is not FDA approved for the treatment of asthma. However, it has been shown to be effective as a monotherapy as well as in combination with tiotropium bromide in animal studies. Breo-Ellipta. Breo-Ellipta is also a long-acting, an ultra-long-acting beta agonist that is FDA approved in fixed combination with fluticasone such as Anora-Ellipta, or in combination with fluticasone and Umeclidinium Trelegy. It's been studied as a single therapy with effective results in patients with COPD. It is not available as a single therapy. It is only found in combination with other drugs. Here is the Breo-Ellipta, and it's a combination in combination with fluticasone. Things to watch out for when using long-acting beta-2 agonists. They should not be used without a controller medication, by patients who are controlled on low dose or even medium dose inhaled corticosteroids. They should be used only if patients are not controlled by inhaled corticosteroids and for short term only. Children must use them in conjunction with a corticosteroid. Mechanism of action. The bronchodilating action of adrenergic drugs is caused by the stimulation of the beta-2 receptors located on bronchial smooth muscle. In addition to beta-2 receptors, some adrenergic bronchodilators can stimulate alpha and beta-1 receptors with the following clinical effects. Alpha receptor stimulation. Alpha-1 receptor stimulation causes vasoconstriction. It can have a vasopressor effect. In the upper airway nasal passages, this can provide decongestion. Beta-1 receptor stimulation. This can cause an increased myocardial conductivity, heart rate, and contractile force. And beta-2 receptor stimulation. This causes relaxation of the bronchial smooth muscle with some inhibition of inflammatory mediator release and stimulation of the mucociliary escalator, which enhances mucus clearance. The mechanism of action of beta agonists and the beta receptors has been well characterized, although the activity of alpha receptors is not as well understood. The mechanism of action for relaxation of airway smooth muscle when a beta-2 receptor is stimulated can be seen in your book in figure 6.10. Adrenergic agonists such as albuterol or epinephrine attach to beta receptors, which are polypeptide chains that transverse the cell membrane 7 times and have an extracellular NH2 terminus and an intracellular carboxy terminus. That's a mouthful. This attachment causes activation of the stimulatory G protein designated G1. The actual binding site of a beta agonist is within the cell membrane, inside the barrel or circle formed by the transmembrane loops of the receptor chain. The beta agonist forms bonds with elements of the 3rd, 5th, and 6th transmembrane loops. When stimulated by a beta agonist, the receptor undergoes a change that reduces the affinity of the alpha subunit of the G protein for guanosine diphosphate, or GDP. The GDP is replaced by guanosine triphosphate, or GTP, and the alpha subunit dissociates from the receptor, and the beta Y portion of the G protein link with the effector system. The effector system for the beta receptor is adenyl cyclase, a membrane-bound enzyme. Activation of the adenyl cyclase by the alpha subunit of the G protein causes increased synthesis of the second messenger cyclic adenosine 3,5 monophosphate, or CAMP. CAMP may cause smooth muscle relaxation by increasing the inactivation of myosin light chain kinase, an enzyme that initiates myosin-actin interaction and subsequent smooth muscle contraction. An increase in CAMP also leads to a decrease in intercellular calcium. Whew. What that means is the B receptor binds to a B receptor, ultimately causing an increased synthesis of the CAMP. The alpha receptor inhibits the release of the neurotransmitter from the presynaptic neuron. It can also lower the synthesis of intracellular CAMP. Alpha-1 receptor activation. Stimulation of the alpha-1 receptor by an agonist like epinephrine, which has an affinity for both alpha and beta receptors, results in vasoconstriction of the peripheral blood vessels. Let's talk about long-acting beta agonist mechanism of action. The mechanism of action for LABAs in providing sustained protection from bronchoconstriction differs to a degree from that of the previously described adrenergic bronchodilators. The difference in the pharmacodynamics of a LABA is reflected in its pharmacokinetics, with a slower onset and time to peak effect and a longer duration of action compared to previous adrenergic groups. The structures of a long-acting agent can be seen in figure 6.7 in your book for comparison. The agents are a modification of the selinogen albuterol with a long nonpolar N-substituted side chain, a big long side chain that hangs off of it. These are a lipophilic side chain, which is attached to the B receptor laterally. As a result of this structure, Salmeterol is lipophilic in contrast to most SABAs, which are hydrophilic or water-loving. And it approaches the B receptor. They can approach the B receptor directly from an aqueous extracellular space. In contrast, salmeterol, as a lipophilic molecule or a fat-loving molecule, diffuses into the cellular membrane phospholipid bilayer and approaches the B receptor laterally. The lipophilic nonpolar side chain binds to an area of the B receptor referred to as an exosite, a hydrophobic region. It doesn't like water. With the side chain or tail anchored in place, the active selenogen head binds to and activates that beta receptor at the same location as albuterol. The binding properties of the LABAs differ from those of albuterol and other SABAs because the side chain of the long-acting agents is anchored at this site. The active head portion continually attaches to and detaches from the receptor site. This activity provides ongoing stimulation of the beta receptor and is a basis for the persistent duration of action of long-acting agents. So how do we give these? B-ADRENERGIC bronchodilators are currently available for inhalation as metered dose inhalers, nebulizer solution, dry powdered inhalers, and RESPIMAT. They can also be given orally in the form of tablets, syrup, or sprinkles, and they can be injected through IV. Regardless of the route of administration, there are 3 general patterns to the time of bronchodilation with drugs in this group. Catecholamines have a rapid onset of 1 to 3 minutes and a peak effect of 15 to 20 minutes, and then a rapid decline. Non-catecholamines like resorcinols and selenogens, with the exception of salmeterol, show an onset of 5 to 15 minutes, a peak effect of 30 to 60 minutes, and a duration of 4 to 6 hours. Salmeterol differs significantly with a slower onset, greater than 20 minutes, and a peak effect in about 3 hours and a 12-hour duration of effect. Formoterol and R-formoterol are similar to salmeterol in duration, but have an onset as rapid as that of albuterol. Indacterol and oloderol and vilanterol all have a duration of effect that is at least 24 hours. Catecholamines are not effective orally. Benefits of inhalation include rapid onset, smaller doses, reduced side effects, and the drug delivered directly to the target organ, the lungs. They are relatively safe and painless. Limitations are time, public embarrassment, and difficult to use correctly. You see the child here pictured with a spacer with their metered dose inhaler. Not always the case. Let's talk about continuous nebulization of albuterol, which can be used in the case of someone in an acute asthmatic or bronchospastic episode. It's used for the management of acute asthma. It reduces the need for frequent respiratory therapist attendance. You're not giving a treatment every 10 to 15 minutes. And in an adult, they usually give 10 to 15 milligrams an hour. In a child, you may see a lower dose of 5 to 7.5 milligrams per hour. And at these larger doses, generally they will need to be in a monitored area. When using continuous nebulizers, things to consider are the refilling of the small volume neb, a volumetric infusion pump, or the use of a large volume nebulizer such as the heart neb. There can be toxicity and potential side effects like cardiac dysrhythmias, tremors, hypokalemia, hyperglycemia, but the most common are shakiness. And again, they should be monitored. The oral route has advantages of ease, simplicity, and short time required for administration. However, in terms of clinical effects, this is not the preferred route. The onset of action takes 1.5 hours, with a peak effect reached after 1 to 2 hours, and a duration of action of only between 3 to 6 hours. Larger doses are required than with inhalation, and the frequency and degree of unwanted side effects increases substantially. The dose has to be increased due to loss in the first pass through the liver. The liver just chews it up. Given IV, this is used only in emergency management of acute asthma. It's thought to be useful when obstruction prevents penetration of the aerosol to lung periphery. Typically, you'll see sub-Q or just under the skin epinephrine given as an 0.3 milligram injection, or subcutaneous, just under the skin, terbutaline as an 0.25 milligram injection. It should be used as a last resort and requires infusion pump, cardiac monitor, and close attention for systemic side effects. Adverse side effects include tremor, cardiac effects like increased heart rate, tolerance to the bronchodilator effect, loss of bronchoprotection, central nervous system effects, a fall in PaO2, metabolic disturbances like hypokalemia, propellant toxicity and paradoxical bronchospasm, and sensitivity to the additives. Let's talk a minute about the beta agonist controversy. This is called the asthma paradox, where even though we have increased evidence of asthma mortality and morbidity despite great advances in treatment, some of the things they think are a lack of a corticosteroid, the possible loss of the bronchodilator effect, an increase in possible bronchial hyperreactivity, and exposures to triggers with no immediate symptoms. There is some evidence to show increasing asthma mortality and morbidity due to temporary relief that leads to a delay in seeking acute care help, poor patient compliance and education, not taking short-acting bronchodilators when they have an immediate need and only taking a long-acting bronchodilator, accumulation of the S-isomer in the tissue, and exposure to environmental pollution and lifestyle changes such as obesity or poverty also have been found in some of the studies. So, what does a respiratory therapist assess when you're doing beta agonist therapy? You want to look for effectiveness of the drug based on indications for use, monitor peak flows, Perform physical assessment before and after a treatment. Monitor the heart rate for a 20% or more increase. And any subjective reactions voiced by the patient. I feel better. I feel worse. Look at your ABGs before and after use. Monitor potassium and glucose levels. Pre and post PFTs can also tell a story. And provide patient education about the difference between a rescue beta agonist and a maintenance beta agonist. Instruct and verify correct use of all devices, including metered dose inhalers, spacers, respimats, and dry powdered inhalers. For long-acting beta agonists, make sure to assess ongoing lung function at least annually, assess the use of a rescue drug and nighttime symptoms, ask about the number of exacerbations per week, ask about the number of days absent from work if an adult or school if a child, and look at the ability to reduce the dose of inhaled corticosteroids. Have you gone up on daily inhaled corticosteroids or down? Thank you for your time and attention. This is the end of our program.